Okay, so let's talk about risk factors for atherosclerosis, and then we'll hit on management, and we'll be done. Again, so obviously, as you can pick up from the last video, our really the biggest or number one risk factor would be your dyslipidemia, and we talked about why that is. The increase in low density lipoproteins building up in the blood means that more of them can be oxidized and turned into foam cells, and then have plaque buildup. Without the LDLs, there really are no foam cells. There's no plaque buildup. There's no interference with blood flow and all of the other problems. Aside from that, your major, I know I've hit on this like 3 or 4 times, but your major factors or risk factors would be your hypertension, smoking, and diabetes. So if you hit a question on an exam, a select all or what have you, these are really your main ones: the dyslipidemia, hypertension, smoking, and diabetes, although the others are important as well, and we'll go through them. These are like the main ones. In terms of hypertension, it's important that you know what qualifies hypertension, right? So it's a sustained blood pressure over 130 to 90. So this isn't something that's happened once or twice. It's something that, you're taking your blood pressure every day for a month and it's high. And again, make sure you keep an eye on this, because the system, the grading system for hypertension has changed in Canada in the last year. So just, it used to be a little bit higher than this, and now it's 130 on 90. One of the reasons that hypertension can increase the risk of atherosclerosis is that that speed of the blood moving and the pressure in the tube or in the vessel, the blood vessel, can actually create a shearing stress on the inside wall or the endothelium of the blood vessel. So if you just imagine like a river that's flowing, really, really, really quickly, high pressure, really fast, it's going to do kind of damage to the riverbed, right? The sides. But if you have a stream that's kind of slow and it's low pressure, and it's really not going to be creating any kind of stress on the riverbed, right? And so there won't be as much damage to the sides. And so that's kind of, I don't know, that's kind of how I think of it, like in terms of how blood pressure really affects atherosclerosis. The other thing is that it's kind of a cyclical problem, because remember we talked about how in atherosclerosis, one of the things that happens is the inflammatory mediators cause proliferation of those smooth muscle cells in the wall of the artery. I think if we look over here, we can kind of see where we talked about that. Right, it creates increases these muscles and makes this wall here thicker. If you look here, this was a much better view of how that wall gets thicker. And like we talked about, when that wall gets thicker, it's less elastic, it's not able to respond to or accommodate to increases and decreases in blood pressure. And so that actually in itself is going to increase blood pressure. And then that blood pressure again is going to, increase the shearing stress. And it's kind of a cyclical problem. Smoking has a lot to do with the release of epinephrine and norepinephrine. So smoking actually does cause a release of these catecholamines, right? And we talked about what do those kind of catecholamines do to blood pressure and heart rate, right? They're going to increase those. It's that fight or flight response. And so when you have an increase in blood pressure, increase in cardiac output, increase in cardiac workload, because of that release of epinephrine, norepinephrine, you're going to have an increase in the damage to that endothelium. It does also have an effect on the release of those free radicals. So it contributes to the inflammation and the thrombosis and what have you. If any of you are, one of the ways I remember that this is just that relationship between like birth control and smoking and thrombosis, right? We're supposed to, they always ask you before they put you on birth control or any kind of hormone therapy, whether or not you smoke. And that's why, because there's a higher risk of thrombosis in people who smoke. And then one of the other interesting things that can happen is well, the effect of carbon monoxide on your hemoglobin. So we know that hemoglobin is it's basically a protein that carries your oxygen through the body, right? And it does that through these kind of receptors. And so the oxygen molecule, for example, will attach to that receptor on the hemoglobin and then travel that way. But carbon monoxide actually uses the same receptors on the hemoglobin. And so with carbon monoxide, what will happen is you will have all of those or a number of those receptors taken up, and there isn't enough or aren't enough receptors for an appropriate amount of oxygen to be carried through the body. Now, it's not as much of a concern, when you're smoking one cigarette, but it's definitely a concern with higher doses of carbon monoxide or long-term doses of carbon monoxide. And so this is actually something that comes up in NCLEX prep a lot, what carbon monoxide does and what the effects are. So it's good to know that. For this unit specifically, I think it's just important to know that it's going to, decrease the oxygen availability for the heart. And so if they have less oxygen available, you're increasing the cardiac workload, and that's going to have an effect on blood flow and the possibility of developing or worsening atherosclerosis. And then, just something to remember that secondhand smoke also causes all of these risks. So if that comes up on a test, won't want you to miss that. And then it is important to know that smoking cessation. So if people stop smoking, you will see a change in their overall health very, very quickly, but a change in their cardiac health very, very quickly. And you can see how that happens because you don't have that sudden release of epinephrine and norepinephrine that's constantly happening. People are smoking a cigarette every couple hours, and you're having this release every couple hours. You can just imagine what that's doing to your body. And so those are really your big ones. So the dyslipidemia, hypertension, smoking. I'm going to skip obesity for a second and just talk about diabetes, because it's really, one of those top 3 or top 4. You're actually 2 to 4 times more likely to develop coronary artery disease if you have diabetes. Many people don't even realize they have diabetes until they have like a coronary incident. So they come in and they're having a myocardial infarction or having a heart attack, STEMI, NSTEMI, whatever you want to call it. And that's when they realize that it was caused by this increase in glucose or glucose levels, sustained glucose levels. So if you're diabetic, you're more likely to develop atherosclerosis at a younger age. And it actually kind of nullifies this whole gender difference here. So we talked about how, men are at a higher risk around 40, women around greater than 50, depending on whether or not they're postmenopausal. If somebody is diabetic, if a woman is diabetic, it kind of just negates that entire difference. So they would be as at risk as a man at the similar age. And we don't really necessarily know the mechanism behind this. We do know that diabetes affects the body's ability to heal. So we know that it would have an increase, like a effect on like endothelial dysfunction and its inability to repair itself, and therefore increase the presence of the fatty streak and the development of the fatty streak. But other than that, there isn't like a whole lot, really complicated kind of explanation. It really is just the damage to the endothelial. And so obesity and metabolic syndrome, I'm going to kind of talk about these at the same time. Obesity, make sure, I don't know for this exam, but make sure you know a regular BMI, which I believe is 18.5 to 23. Don't quote me on that top number. Double check it. But these are things that put you at higher risk. Really nowadays or whatever, we're more concerned with waist circumference than BMI. And that's because waist circumference, there's been tons of studies showing that kind of central obesity, like if you're carrying weight in the middle part of your body, can put you at a much higher risk for coronary artery disease. I don't necessarily know that there's like a really good patho behind that, but it's just something that they're really in the last 20 years are developing. This metabolic syndrome is really like a cluster of risk factors for heart disease. So it's these four kind of risk factors. You have the large waist circumference, which I just talked about, hypertension, abnormal serum lipids or dyslipidemia, and elevated fasting blood glucose. Those are the four, like, if you have those four or three out of those four things, they would say you have metabolic syndrome. Metabolic syndrome in itself isn't necessarily a disease. It's like really just putting you at a higher risk for coronary artery disease. And you can understand how we know how hypertension affects blood flow and cardiac output. We've talked just today about how dyslipidemia can affect atherosclerosis and then blood flow and so on. So these things are it's just really important to be able to recognize what metabolic syndrome is and what it's a risk for, and B, what all of those four kind of risk factors are. So just make sure you know that. That does tend to come up in NCLEX prep a lot. And I find sometimes there's like these little tiny portions of your study notes and it'll be like 4 questions on the exam. So it's just a really good thing to understand. Sedentary lifestyle, we know that increases the risk for thrombosis because exercise improves blood flow and improves thrombolytic activity, and encourages the development of collateral circulation. It's really, really important to understand the psychological state, how it can affect kind of your risk for coronary artery disease. So I think I saw a lot of slides or information on the Framingham study, which is basically just this like ongoing study. It's been done in Framingham, Massachusetts. That's why it's called Framingham study. It's really like the most kind of important coronary artery study of this century. In fact, those anti-smoking campaigns that started in the 70s and 80s came out of this study, the realization of how, or the discovery of how smoking was affecting our bodies and so on. Part of what that study has been showing is that there's evidence that certain behaviors and lifestyles can increase the risk of coronary artery disease. And they talk about how, whether having like a type A or a type B personality, how a type A personality, like a perfectionist, hardworking, driven, overachiever, how they will have a higher stress level and how at a higher risk for CAD. And then type B would be more easygoing, has a decreased risk for CAD. One of the other things that's important to know is that people who have chronic or acute stress or depression are also at an increase of coronary artery disease. And you can put that together on a test because you know that an increase in stress is going to increase your catecholamine release, which is going to kick in your sympathetic nervous system, increase your heart rate, your workload, oxygen demand, and so on. This homocysteine levels, Homocysteine is a hormone that's produced during the breakdown of, I can't remember the name. Look, methionine or something. It doesn't matter. It's an essential acid, amino acid that's found in dietary protein. So when it's broken down, it releases kind of this homocysteine. An increase in these homocysteine levels damages the endothelium, promotes plaque buildup, and alters clotting and increases clotting. And there's a relationship between homocysteine levels and B complex vitamins, so B6, B12, and folic acid. As your B12 goes up, your homocysteine goes down. So they have this kind of counteractive or counter whatever relationship. So people with pernicious anemia, we know that pernicious anemia is a decrease in vitamin caused by decrease in vitamin B, right? Will have less vitamin B, but will have high homocysteine levels and will be at a higher risk for coronary artery disease. And then substance abuse, mostly cocaine and methamphetamines. These can cause a coronary spasm that looks and feels just like an atherosclerotic MI or angina. Patients will come into the ER, sinus tach, increased blood pressure, chest pain, anxiety. Like they have all like the symptoms of a myocardial infarction. And most of the time what it is it's that coronary spasm that has created a temporary kind of blockage in the ability for the blood to flow. And then when we talk about non-modifiable risk factors, we're talking about, there aren't a whole lot for this. Age, of course, it increases with age. Well, gender. Now, this says men have a greater risk than women until they're 65. Over here, we talked about over 50. Something I've had to learn, or I had to learn during nursing school, was that you do find competing kind of bits of information depending on what textbooks or slides or your profs, and you really have to learn to dig out what actually matters. And so what matters and what we're seeing here is that men are more likely to have coronary artery disease until women hit a certain age, which would be somewhere between 50 and 65, where their risks would increase. And that likely has to do with estrogen levels. So one of two things can happen with a discrepancy like this. One, you could have a question on an exam that's very specific to this, in which case you'd have to go to your prof and say, look, the slide said this and the book said this, and try to have it out at that point. I find that to be almost pointless. The really what's important is remembering, what matters. If you lose a mark because of that kind of discrepancy, it's not a big deal. You will not find that on an NCLEX. You will know what you need to know. There's a right and a wrong. You're not going to have to be left guessing. For example, I know a lot of students, let's take like potassium levels. Some textbooks say regular 3.5 to 5. Some say 3.5 to 5.2. The point is that high potassium is going to be somewhere above 5.2. And really, if you have a question on that on the NCLEX, it's going to say, potassium was 5.9 or 6.1. They're not going to ride right on the line. And if they do ride right on the line, like if it's 5.1, for example, or 5.2, that actually means something. It's slightly high. So I guess what I'm trying to say is those numbers, they're not as black and white as we would like them to be. It's kind of a guideline. Everybody's different, right? And so back to this risk level, really what it's saying is that as women get older, their risk increases and begins to equal that of men. Again, if you have something more specific, you'll have to take it up with your prof. It's more prevalent in Caucasians. And then genetic predisposition or family history. When it comes to genetic predisposition, it's a really, really important factor. We're not exactly sure why or where, where the gene for specifically for coronary artery disease or exists, but it's we know that people with a family history, and family history meaning somebody one level above or below, so like a parent, a sibling, what have you, are at a very, very high risk. Most people who do have a coronary event can identify like a parent or a sibling who has died of coronary artery disease. And then the other, kind of genetic thing would be your familial hypercholesterolemia, which is basically just a gene mutation that, kind of affects the LDL receptor. It's somewhere between 1 in 200 to 1 in 250 people. Like that's how common it is. You'd have high LDL levels at a fairly, and you'd start to show like atherosclerosis, signs of atherosclerosis at a fairly earlier age than most people. So maybe in your 30s instead of, 40s, 50s. So this is really just, again, we don't know a whole lot about it. We just know that this gene mutation causes people to have an increase in LDL and cholesterol throughout their entire life. And we know what that would do in terms of a risk for coronary artery disease. So when we look at like a management or like health promotion, these risk factors are really, really huge. When we're talking about coronary diseases at all, screening people for risk factors is just really, really important. And for CAD, we want to look at these kind of 5 main things. The first is a family history, and we talked about why that is, right? We know that they're way, way more likely if there's a family history. Presence of any cardiovascular symptoms, so shortness of breath, chest pain, anything like that. Even like exercise intolerance, anything like that. Environmental factors, they're talking more about like diet and exercise here. So if you have someone with a sedentary lifestyle who eats a lot of high fat foods, right? And then psychological factors. So they're going to look at, psychosocial factors. They're going to look at levels of stress, anxiety, and depression. But also whenever you see psychosocial, we're also talking about any kind of substance use. So tobacco or alcohol. And again, anytime you see alcohol or tobacco, it's definitely something we want to avoid. If it's a select all that applies, select it. And then the last one is employment. Because the types of activities performed can tell us whether or not the patient has been exposed to any kind of chemicals or pollutants that could increase cardiac workload or affect the endothelial layer, and then also depending on the amount of stress that is associated with that work. So selling coconuts on the beach is probably a lot less stressful than like a high power corporate lawyer, for example. And so knowing where the person is employed can really give us an idea of how much stress they're putting on their body and in their life. And so if you look at these kind of major risk factors, it's not a lot of information. I've gone through each one like really, really detailed so that hopefully you'll be able to remember when you are tested. But they're really a lot of the same kind of risk factors you hear for everything, right? And again, hypertension, smoking, diabetes, and dyslipidemia are your main 4. And then, but obviously all these other things are going to have an effect as well. Okay, so second last video, we're gonna move on to the next video. We'll cover the management of coronary artery disease or atherosclerosis, and then we're done.